Welcome, everybody, to another episode of the GC Orthodontic Exchange podcast. This is Antonino Secchi from Devon, Pennsylvania. And today I'm really happy and excited to have my good friend, Dr. Francisco Eraso. Dr. Eraso is a dual specialty, actually. He's a maxillofacial radiology from Chapel Hill, North Carolina, and orthodontics from Indiana University. So, Dr. Eraso, welcome to the podcast.
Thank you.
And I'm going to let you kind of introduce to the audience to talk more about your experience in this kind of dual specialty that you have. Please, go ahead.
Thank you, Antonino. It's a pleasure to be with you as always. And imagine this. I came 30 years ago to United States to watch the World Cup.
Oh, good.
And I decided to stay. And so when I stay, I always want to be an orthodontist. But it was very difficult to get in. Money, language, I didn't speak the language.
Yeah.
And so I decided to go into a specialty that maybe is not in my country. I was planning to go back to Colombia.
Okay.
And so I said, radiology. Radiology is the one that everybody needs, and I think it's a good one. So I visit the city right next to my city. I was in Cincinnati. I arrived to Cincinnati. And then I went to Louisville. And in Louisville, there was one of my mentors, Dr. Alan Farman.
Okay.
And he listened to me. And I couldn't understand anything that he was saying. But that was his smile. You know,
I was
like,
wow.
yeah, whatever, yeah. And so I smiled to him, and he said, I want to shadow you. He said, yeah, but the school usually charge a fee for that. It's called preceptorship. And so it's like, okay, it's like whatever money we agree. And after 2 months, he said, Francisco, something, that I'm not going to teach you, because it's like you are shadowing me. So I think it's better if you do a master's. So he said, he guided me to do my master's in oral biology at the University of Louisville. And that allowed me to learn the language. My co-director was from Australia.
Oh, wow.
Alan was from London. And I was in Louisville, so I didn't understand anybody. Anyway, but I learned, and Louisville teach me how to do research. And then I went to, I tried to get into ortho, but I was still not good enough for the application. And so I went to Chapel Hill to finish my residency in radiology. Chapel Hill had a specialty program.
Nice.
Finished in 1998. And in 1999, the ADA approved radiology as the last specialty approved by the ADA. So great, I'm a trained with a certified specialty in the United States, so I can take the boards. I can sit in any state. So I was working in my boards and everything, and I went to practice. I went to teach at Nova Southeastern University in Fort Lauderdale, and I teach for 5 years, and I got tired. I reached everything. I became an associate professor. I was the chair of the department, but I want to touch the patients. I want to feel that contact.
Yeah.
The feeling of treating patients. It's awesome to shake hands, to change lives, and especially to deal with little kids, because I'm a joker with the kids and everything. So I love that. And so at one point I said, okay, now I want to do orthodontics. So Gene Roberts, Gene?
Yeah.
Gene is another mentor that I have. Mm-hmm. And Gene said, Francisco, I want to have you in my program in Indiana. And so he invited me to interview, and I went to my second specialty, my third master, my second specialty, which is orthodontics in IU.
Wow.
And so
that's amazing.
And the interesting thing is, I thought that I was not going to do radiology. Just to finish my story. I'm sorry for the long introduction.
No, it's good. It's good. Yeah.
So then, when I was in 2004, radiology, or the ICAT, or the Combine CT became extremely popular. With one presentation, there was a professor called Sharon Brooks. She works in the company that I work, Bean Readers. And she presented that the radiation dose of the ICAT or the Combine is equivalent to the radiation dose of a conventional lateral safe and panoramic. And from that point, radiology became like or Combine became popular. And there was no radiologist. So I finished orthodontics in 2005, but the people had more need for radiologists than orthodontists. So I practice from 2005 to today the two specialties. We found a company called Bean Readers in 2008, By the way, yesterday it was 17 years ago that we started that company.
Wow, congratulations.
We did 200 cases. I report 200 cases. Today we read 120,000 cases per year. I personally read maybe 10,000 cases. So
10,000.
So I'm really into diagnosis, and that is why radiology and orthodontics is the perfect combination for me. I do both.
That's fascinating. So they send you the files, the COM-beam files, the DICOM, and you have to write the
report.
The report.
Mm-hmm. And a lot of people. As you know, you are responsible for everything that has in your practice, all of the records and everything.
Yeah.
You're responsible to analyze them. And most of the people don't have neither the knowledge or the time. Maybe they have the knowledge, but not the time. So the discipline to read every single case is very difficult, even for the people that have COM-beams and they do it every day. So some people say, I'm going to have some questions and send it. Some people send all of the cases. And we do sometimes, you remember Gerber in the book, says that you have to segment the anatomy in different compartments, the science and everything.
Yep.
And so we produce something that's called imaging portfolios. And the imaging portfolios is literally having pieces of information that creates the foundation for diagnosis. And that information is, together with the report, is what we do.
Wow, that's really impressive. Now, most of the people who send you these cases are orthodontists, or also
30% of the 110,000 people are orthodontists.
And the rest is just other...
TMJ is popular, implants are extremely popular, pathology.
Wow, and that's great.
General,
I don't know how you have the time to do orthodontics and also read all these images. That's really impressive.
Discipline. I'm not that disciplined, but sometimes I'm disciplined.
Yeah.
So let's say, for example, I was telling Dr. Maser that I like to travel a lot. So when I travel, I still work. So I wake up at 5 a.m. to 10 and read x-rays. Wow. So that will allow me to do radiology all the time. And in my practice, I try to practice 2-3 weeks max. Condense the schedule really well with the things that we're going to talk now. With good technology, good brackets, good systems.
Switching gears here, and I know that you do a lot of hybrid treatment, aligners and braces. So how you integrate that, and what do you think is the value of it? I mean, tell me more about how you see this hybrid treatment going forward.
No, it's interesting. It's not like I'm the king of hybrid treatment now. Yeah. Let's put it this way: everybody does hybrid treatment every day. But what I do with GC, and when we start to put together stuff and have the strengths of the company up, good chemistry, good products, good people.
Yeah.
And so what we do is have the strengths of every product, and to the benefit of the patient and of course the doctor. I want to finish the case in 12 to 14 months. You are very good doing that. Sometimes you only need braces. You don't need...
Yeah.
But I budget the case. And this money is for the case. And the rest is profit. So I budget my brackets, my wires. I don't buy a Ferrari and put economic gas. I got the best wires, the Bioforce wires. Then I talk to the patient that... Because... To be honest with you, who wants to have braces for 3 years?
Yeah.
Sometimes we do cases for 3 years, but because we don't know what is going to happen. But if we plan correctly and we correct the most difficult part, correcting class 2 and class 3, of course, we can use the multifunctional appliance, we can use any other appliance. But that is a completely different story. But when you have a big rotation and you pretend that you're going to correct that with aligners, it's a waste of time. So you're going to have refinements, even if the system is the best system in the world. Yeah. So you have to prepare mentally, and you have to prepare the patient. And preparing the patient is to tell him, hey, you're not going to spend more money. Which is I'm going to use, these are the tools that I'm going to use. And some people don't want to have aligners because, for example, my patients are very Hispanic. A lot of people that are working in companies and factories and everything. They cannot take everything out. And they say, no, doctor, I don't have the discipline or I don't have the time. So then you maximize your treatment facility or tools just using the right braces and wires.
Yeah, that's very interesting because I have also some Hispanic patients and that they work in different restaurants or whatever fields. and they actually like braces. They actually want braces. It's almost like a status thing that they like. Yeah. So they ask for braces specifically. Talking about adult. Yeah.
I was talking with somebody in the break, and people wants to show that you are taking care of yourself, and that's a good point that he make.
Yeah.
And people, it's like, for example, people we're losing all of our hair. No, at least me.
At least me too.
So a lot of people go to Turkey and they do surgeries, and the people they are not ashamed that show that you are taking care of yourself. Surgery, plastic surgery.
You're right.
The same thing with braces. People love to show that they have braces, but what they want to know is, I want to put braces, but I don't want to have the braces for 3 years. Especially if I'm a 45-year-old, or I'm 50, or I'm even 60 years old. Yeah, they want to have it for a year, but they don't want to have it for 3 years. So then you combine the strengths of braces and aligners, and you propose.
So in those cases, you typically start with the leveling and aligning with braces, just to correct most of the tough movement, and then you switch them to the aligners?
Whatever is more difficult. So if it's a class 2, I don't do class 2 corrections with aligners. So I will waste my time. So correct first the class 2, and then I do aligners. Correct maybe because sometimes even I use a three approach. Sagittal correction, correction, the big rotations and everything, and then I detail with aligners. Just detail is maximize the beauty of the case.
Yeah.
Because I don't know if you did that in your program, but remember that we used to take models like 2 weeks before, 2 appointments before you finish, just to see what you need to detail. So you take models, and now you have a model in your hand. I was like, oh, okay. Oh, I didn't see this one when I was doing my exam.
Yeah.
So that's what we do with aligners. We take a good impression with the braces on. That is the beauty with MOV'Aligners, with the braces on. So it's like, oh my God, I look at this. This is the two that I need to correct the most. Maybe I need to close this little gap. So rather than keep going with braces and just finish with the aligners. At the same time, you do an easy case with aligners. Doing easy cases with aligners is a pleasure because it's just a simple thing.
Yeah, simple. So talking about the MOV'Aligners that GC Orthodontic introduced just recently, how's been your experience with the MOV'Aligners? Software-wise and the materials, and can you tell us something about that too?
But let me ask you something, Antonino, before I answer. How often do you use aligners?
In my practice, probably 30% right now is aligners.
And you use aligners for 20 years?
I mean for a long time. Huh? Not 20 years actually, but
close.
Longer than
15.
Yeah.
We're getting up. So in my practice, I try to use aligners as much as I can, especially with the lifestyle that I want to travel. I don't want to worry about emergency and everything. And as long as the patient is disciplined and you have the conversation with patients and you know which cases are good.
Yeah.
So MOV'Aligners is a choice that has a strength in my kind of work. So if I want to use braces and aligners, I don't want to spend too much money with aligners, and I don't want to spend too much money with the braces, and then I don't have any profit.
I see.
So MOV'Aligners is a solution that takes the strength for the brackets that I use, the self-ligating experience brackets, with the wires that I use, and maximize the finishing and detail. So it's a good combination as a product together. It's perfect.
Nice. And you find the software to be very easy to work with, has all the tools that you typically expect from a software with aligners?
It's kind of we're preparing these questions, huh? And remember that I'm a radiologist, okay? So I don't know how people do treatment plans without seeing the roots.
Yeah.
So MOV'Aligners, as well as other companies, they don't see the roots in the treatment plan. So what I do is, in my indirect bonding setup, I use a software that allow me to segment the roots and the bone.
Okay.
So I know I'm not taking the roots out of the bone when I plan.
I see.
So when I use the strength of that technology in the first phase, which with braces, I'm going to finish the case with no problem. Now, if I don't use the CBCT to segment the roots and to segment the bone, because remember, we're moving roots through the bone.
Yeah,
it's not like so can you imagine people doing aligners for 25 years without seeing the roots on the bone.
Yeah.
It's kind of like, this is going to happen. But
I guess, yeah.
if we take Combin in every single case, most likely we're going to find that we produce something, not all the time, but sometimes the roots are a little off or out. And so I want to prevent that. So I use the maximizing the technology because the Move software doesn't have that. I'm using that in the first portion of the treatment with the dips and the GC software.
Nice.
And position the brackets in the right place and finish with the aligners. So the software for Moves is a very typical software. You know how you're going to move your teeth. You put your attachments. You use your IPR. It's a software that you will get used to it very fast.
Very fast, yeah.
It's not complicated.
Nice. And now again, talking about wires, because again, we've been talking about just recently that for many people, wires are a commodity. They don't see the value, and we've been working with what I think are the best wires ever, and currently the best wire that you can get. So, can you tell us a little bit about what is the importance that you see of the wires in the orthodontic cases, and what do you think would be some of the advantages or differences or uniqueness of the Tommy GC wires that we use?
Yeah, it's a great question, Tonino, and this is what my take on wires. Okay, because we have such a good diagnosis and treatment plan that creates the foundation. We know how the wires are going to behave moving the roots, okay? So if we had those wires with different shapes, but also with different forces, it's like putting the best gasoline to finish first.
Yeah.
So you and I you like Formula One?
I love it.
Yeah, okay. So you are Hamilton, I'm whatever, the Verstappen, okay? If you use no good gas and I use premium gas, who is going to finish first?
Yeah, of course.
So the other thing is that people don't realize that the how much we spend in wires is not that much. So why using cheap wires or wires that will not go with the technology that you are using? Imagine that I'm using experienced brackets, I'm using MOV'Aligners, and I'm going to use different wires, because I want to save money.
Yeah,
save money for what, So if you want to finish consistently, you use the best technology together to finish the case, and that is what I'm using the wire. So the wires, we can also move the roots in the software using the shape of the wire, so we know the limits, the boundary, the biologic boundary limits when we use that force with that wire. Mm-hmm.
We used to say, we still say that an expensive bracket with a cheap wire is a cheap system. They go hand by hand. Yeah. So specifically about the forces of these wires, like the bioactive and the initial oil wires, that people are always concerned about how you engage all these displaced teeth with one wire. What about the secondary effects? And I'm trying to explain to people, listen, it's the same force in the system if I engage a canine that is 5 millimeter displaced or 1 millimeter displaced. The force that the wire is going to generate is exactly the same. Yeah. So do you agree with that? With this?
I agree, and I enjoyed your lecture, the webinar that I was listening with these people in Chicago, and I enjoyed your lecture, and I was like sometimes I'm really careful with the forces that we put, especially with a very crowded segment in the interiors, and so I saw you very comfortable using all of the wires everywhere, wow, so I'm going to try it. But, the other thing is the prescription, Antonino. So you are very humble. You never talk about your prescription, but I think your prescription has something to do with the consistency of your results. So a lot of people have to take, in addition to the wires, the consistency of a good prescription. So maybe the prescription is part of the technology that you have. So I'm going to be honest with you. I don't use your prescription. I promise I will. And I have a series of cases that I'm going to use. We are opening a new office, and those brackets are going to be CCO because I want to try. If you don't try, you'll
absolutely.
And then I'm going to do this. What I do now, for example, for the tier segment, is I put coils and open spaces and engage later. Try to be more careful, but
Which is good too. I mean, I use that in severe crack cases with blockout teeth. I typically put a little initial coil in between the two teeth just to open space on an 014. Very gentle forces. I mean, that can be great. I mean, open spaces rather easier. So yeah.
But the discipline of steps, and you consistently go from this wire to this wire to this wire. So a lot of people want to miss steps and cut corners.
Yeah, the protocols.
And the protocols. And I think I was looking at your cases. You are consistently finishing the cases really good with the class 2s, and so you finish it. The beauty of using the experienced brackets is you finish the case with a steel. So it's very difficult to finish a good case without a steel.
Yeah.
To be honest with you. And that is why sometimes the ceramic brackets, for example, from Life Force, very difficult to finish a case perfect. So it's like a...
Yeah. There is another thing that people got confused over the years, in my opinion, is that they start moving away from the stainless steel wires, and the stainless steel wires are still very important. I mean, we have these sophisticated wires for stage 1, where you level and align, you correct the rotations, but the stainless steel used properly at the right time is still a very, very important wire that can level the occlusal plane and do coordinate the arches, do many things that otherwise you cannot do it. And that's very important for the outcome of the case, in my opinion. Yeah.
And after you lecture, what I learned is like as far as the wires, we kind of use the same wires. The 1418 and the 2020. 2020 is a great wire.
Yeah.
And especially if you use the Bioforce. And then you finish with the steel wires, because you can coordinate the arches. Coordination and finishing and detailing is an art. And sometimes it's very difficult. So that is when you say, okay, I don't think this is my last point. Maybe I can move to aligners and do a little tweaking and finish the case without spending that much money, because you're at that point that you are almost going to finish the case. So you can use the aligners to actively retain the case and detail. So
that's nice. Yeah. So you use several software then in your office just to so you do segment the cases by yourself? No. Okay.
That I will not have time to live.
Probably you know how to do it, no?
No, I learned early on that you have to delegate.
Delegate, yeah.
And you have to share the profits too.
Yeah.
So I have some people in South America that help me to do some stuff. I have some people that do treatment planning for in another place. And you have to delegate, because you cannot be good in everything.
In everything, absolutely.
Maybe I look like I'm good.
No, and time.
But it's time. It's all about time.
Personal time. Yeah.
Remember when I talk about the portfolios, the imaging portfolios?
Yeah.
That requires 3 softwares, because there's one software for tracing the lateral shafts. The other software is to organize the photos. And the other software is to segment the roots and everything. That's 3 softwares. That's 3 memberships. So three.
Yeah.
Plus the time. So the good thing about sending it to our company is that we do everything and for a fee. So sometimes I would rather do that than do it and spending hours. I would rather make a radiology report than segment a root.
That's interesting. So your company can actually do all that for orthodontics, from tracing the shaft and segment, roots, and everything.
It's very difficult to trace every single case.
Yeah.
So, but when you have a budget, let's say $100 for records, so you know that is going. I always use this word. I'm creating the foundation because I'm building something. I'm building a beautiful smile.
Yeah.
So the diagnosis is the foundation for my success. So the beautiful cases and the beautiful pictures and everything. Plus, I lecture. And these days, with artificial intelligence, this is our next endeavor, is we have to create, think about this. Invisalign has maybe 50 million cases done, but they never ask you for final records for a reason. I don't know why. But so what we are doing now is some of the people that are creating kind of like a study club. So we're kind of creating templates for the people to upload the stuff. Mm-hmm. And then you tag every step. Let's say class 1, hashtag class 2. It's no hashtag LOL now, but it hashtag every step. So then when you have a number of cases, you create a database. And artificial intelligence is built based on a databases. So we have to create that from the beginning. So for example, with moves, since this is in the early stage, will be nice if we create a step-by-step. Then is a very predictable solution.
Yeah. Not
using AI, no?
The data that you can get submitting the final records, even if it's just the STL files, is huge over the years. I mean, for designing and predicting, it's like the old VTO, the prediction is built on what you think is going to happen based on your experience.
Yeah.
Now we have these STL files before and after. After thousands of cases, you can start predicting pretty accurately, I think.
But and then when we have this database, then we create a digital library, and the digital library is a self-education technology. And so you hashtag class 1 cases, and comes a library of these cases. Hashtag CCO anterior segment. So the beauty of digital data is that we can do those kinds of things. And then education becomes more like a joy. And because how many times giving a webinar is so annoying?
Yeah.
And or how many times flying to Chile?
Yeah.
Because you have some things here is possible,
Yeah,
so then we have to build stuff.
Yeah, well, that's really fascinating. So any advice with all this technology to the younger generation of orthodontists coming? What would you be any kind of advice for them thinking about that they are immersed in this technology, but they still are going to be using brackets and wires for the most part? Yeah.
No, the key is that you cannot have an excuse anymore for failure. Okay, so I remember at one point a lawyer said when the people who do implants they get sued, they make a mistake, they be sued. The judge and the lawyers, I say, hey, can you show me your cone beam? And it's like, no, I didn't take. Why? Oh, because I didn't have it in my office. Oh, but your neighbor or your city or your people don't have a cone beam. Yeah. So there is no excuse anymore for failure. So if you document things very predictable, you are going to have a better life, because you're going to finish cases faster. Nothing worse than to say, oh my God, this is another patient that is already 3.5 years in my practice, and it's because you forgot to do a lot of stuff. And when you document everything and use the strengths of the technology and indirect bonding, digital treatment planning for aligners, and you create the before and after, and you can create pictures, and then you enjoy the beauty of good records.
Exactly.
You have immaculate records, by the way. But when you enjoy the beauty of comparing before and after, you can literally be proud of yourself. And orthodontics, maybe you maybe agree with me, is the coolest specialty in dentistry.
Oh, I mean, this is what we think. I mean, it's a big bias. Yeah. So, Francisco, I want to finish by asking you, since you're a radiologist too, besides an orthodontist, there's a lot of conversation I've seen in social media lately, actually last week, people talking about radiation problems with CTs. There was a big kind of talk about in, I think, one of the Facebook groups, but they were comparing data from a medical CT and trying to extrapolate that to the CBCTs that we use in orthodontics. And also we use CBCTs that actually have the possibility to lower radiation by doing kind of a low, etc. So what do you think about that?
This discussion is what make cone beam the strength. Remember in 2004.
Yeah.
So what is happening? That discussion has been for years.
Yeah.
So Europe is different than the United States. Europe has a very, very the Radiology Society of Europe is very strict in taking CBCT for children. But my point is this, and there is data for that. You can go to Ludlow and different articles and people from North Carolina, and they did a study for every single machine. So the radiation dose for cone beam is equivalent to one lateral CF, a panel, and maybe a set of bi-wings. So that is equivalent to that. So what is happening is this. With the cone beam, we are not just seeing their teeth. We are seeing important structures for the success of our treatment, which are the airways and the TMJ. Yeah. So imagine that you do a beautiful treatment for patient. And by the way, the health of the airways and the TMJ is key for retention.
Yeah.
So if a kid cannot breathe because he has a huge tonsils and adenoids, the mandible is going to grow in a different direction. If the TMJ is not stable, you are going to have different changes in the occlusion. So then you cannot see that in a lateral ceph, even if you take panel, lateral ceph, and bi-wings. So the overview of the maxillofacial complex in a cone beam overcomes the problems with the little radiation dose. In my practice, we use an ICAT, and I don't have anything with ICAT, but that's my favorite machine. 4.8 seconds treatment time machine.
Wow, that's fast.
So in cone beam, patient motion is the worst enemy.
Yeah,
because moving at the reconstruction is not good. And I use 0.3 millimeter resolution size, voxel size. So then with that information, in addition to the diagnostic data that I have, I can use that for diagnostic tools such as indirect bonding, creating, for example, if I want to do in-house aligners, for example, I can do that with that data, put in the roots and everything. So radiation dose is not a concern. Is the excuse like, oh no, there's too much radiation? But the reality is it's cheaper to buy a cone beam than buying the other technology. The problem is time. And I think that is our worst thing. It's not radiation dose, it's time, because sometimes people don't have the discipline to go over the case and to rule out things. And I think that is the biggest problem rather than radiation dose.
Perfect. Well, Dr. Eraso, thank you very much, my friend. It was great to talking to you. So hopefully we'll see you back again at the AO at the GC booth in just a couple of days.
Definitely. Thank you very much, Antonino.